morning. A very warm welcome for the webinar on hematology update from research to practice. With immense pleasure, I would like to invite Dr. Avrita, who is Associate Professor and Head Department of Clinical Hematology, Cancer Research Center, HIIMS, SRHU. Over to you, ma'am, for the welcome and introductory note.
Good evening, everybody. So, as we know that hematology is a dynamic branch and it becomes very important to integrate latest research into our practice. So, I welcome our esteemed faculty and delegates for their active participation and enlighten everyone with the latest updates in the fields of hematology. So, in the day one, we shall be discussing about the updates in leukemia, lymphomas, and hemophilia. So, for the first session, we have Dr. Prakash Singh Shekhawat. He is the senior consultant in hematology and bone marrow transplant at Bhagwan Mahavir Cancer Center, Jaipur, and he will be enlightening us about the ASH 2025 updates on lymphoma. So I welcome Dr. Prakash Singh Shekhawat for the same.
Thank you, Dr. Avriti, for the kind introduction, and thank you, team, for inviting me. Shall I share my screen?
Yes, Dr. Prakash.
So, is it visible to everyone and the full
Yes,
screen
it's
mode?
visible. Your screen is not visible.
Is it visible now?
No.
Wait a minute, let me share it again. Share.
Yes, sir, it is visible now.
It is visible now?
Yes, sir,
Yes,
it is
it is
visible.
visible now.
So we will be discussing AS25 lymphoma updates. There were so many updates in lymphoma this year, like previous years, and I have not chosen everything. I have highlighted a few. Mostly we know in the 2025 and coming years in 26, 27, we are moving slightly away from chemotherapy. So we are going more towards BiTEs and CAR. So as we know, BiTE is bispecific T cell engager antibodies. So one arm is for T cell, that is a usual CD3 uh, domain, and another on the specific antigen which is expressed on those cancer cell. It can be CD20, it can be CD19, 22, kind of this. So BiTEs are like this. For lymphoma, epcoritamab and glofitamab are approved in USA for third line plus for cases of different diffuse large B-cell lymphoma, and mosunetuzumab, which is a subcut BiTE, and epcoritamab, they are approved as third line for follicular lymphoma. So mostly being a BiTE, being a T-cell engager antibody, they produce CRS and sometimes ICANS. These are the common toxicities. Plus, they can cause prolonged hypogammaglobulinemia also. So we know their role is there, especially in relapsed refractory lymphomas and resistant hard to treat lymphoma. So this was the trial which I will be discussing first. So these are very few limited slides of these. Here it was EPCOR NHL1, where epcoritamab was tried as a monotherapy in relapsed refractory DLBCLs, and we can see that those patients who were given this drug, they have sustained response at 4 years. So the overall response was 59% and complete response was good enough, 41%. So almost 46% of large B-cell lymphoma and equal proportion of high-grade B-cell lymphoma, they remained in CR. So mind this, they were previously heavily treated, third line, second line failed patients, and they have been treated with single agent epcoritamab monotherapy, and the response was well maintained till 4 years. So it gives a durable and deep response. And most of the patients, there was no difference between second line and third line failed patients. So it worked even after third line failed patients. So this gives us the hope. In those cases, we can use a single agent, epcoritamab, if they have failed previous line of therapy. Second, This was again when they have used glofitamab versus Gemox or rituximab versus Gemox. So Gemox was the backbone and which was combined with either glofitamab or it was combined with rituximab. And they have done this trial also with a good number, almost close to 275 patients, those who were in good ECOG of 0 to 2. And what they did, they have chosen 8 cycles of rituximab, like most of the trials did in German-based trials. So the patient either received glofitamab with Gemox or they received rituximab with Gemox. And after 8 cycles, the patients also received another 4 cycle of single agent glofitamab. So glofitamab, we know it is a bite and it can cause severe TRS and tumor flare. So it should be given in a stepped up dosing. So all patients with glofitamab in cycle 1, they receive step up dose. First dose is usually 1 to 2.5. Then the second dose 1 week later is 10 mg, and the third dose, which is the peak dose, is 30 mg. From cycle 2 onwards, you can give a single dose of 30 mg. So like here it was used, and we have seen the further stratification was on the basis of relapsed or refractory and 1 versus 2 prior lines of therapy. Those patients who were received glofitamab-based therapy, the median overall survival was almost double. It was 25 months versus 12 months in rituximab and Gemox, and the median PFS was significantly different. So they have shown that Gemox, when combined with glofit, it's a bite. The results are outstanding compared to rituximab alone. So this was another trial, Star Glow trial, which is a beautiful scheme with a 3-year follow-up, and they have shown some good results. Sunmo trial was also another trial. Sunmo is mosunetuzumab. So the latest would have been Mosun trial kind of thing, but it's okay, Sunmo. So they have done mosunetuzumab, polatuzumab versus R-Gemox. And in this Pola-Mosun arm, the PFS was significantly better and the complete response was also significantly better. They have shown that the CR was 51% in Mosun Pola arm versus 24% in R-Gemox arm. And less number of death, good number of achieving CR, and the quality of life improvement was significantly better. The longer it was continued, we see in the third cycle onwards, the quality of life was improving with Mosun Pola, whereas it was never improved with Argemox. It continued to worsen with each cycle. And with 7 cycle and post completion of study, there was maximum quality of life improvement. So this is another trial. Sunmo trial was a hit trial. Then they have again combined glofitamab with polatuzumab. Instead of mosunetuzumab, here they have used glofit pola, and they have shown that if it is used as second line, means after first line failure, 2 plus or 3 plus in relapsed refractory DLBCL, you can expect some good result. The PFS was improved, the OS was better, and they have done this in terms of double eight or triple eight lymphoma in terms of dark zone signature positive. So those where the dark zone signature was positive by cell of origin, they did slightly better. And we see that almost you can say up to 70% of patients were DLBCL or high-grade B-cell lymphoma, and most of them, 75% or more, were in stage 3 or 4. That means a bulky disease, advanced stage, and a relapse patient. So everything was in favor of a bad disease, but the drug combination has done wonders, and we have seen significantly good response with this. So these 3, 4 trials, like the Sulmo trial and the Stargo trial, they show us that these bispecific antibodies are good. They are providing a good response. But can we bring these bispecific antibodies to the front line? Like the polatuzumab was the only drug in last 20 years which has shown some benefit over R-CHOP, a PFS benefit. So can we bring these drugs further ahead instead of a second line and allow de-escalation of chemotherapy? So odronextamab plus chemotherapy was tried in Olympia phase 3 study. And in this Olympia phase 3 study, the drug level 1 was 80 mg and drug level 2 was 160 And in drug level 2, the adverse effect were slightly more than drug level 1. But if we compare these with any treatment emergent adverse effect, or then we can see that it was the main side effect was neutropenia, which is expected, and then the CRS, which is also expected. But grade 3, 4 side effects were not much. They were asthenia, they were diarrhea, slightly 31% versus 13%, thrombocytopenia, neutropenia, and anemia. Being a hematological disorders and being a drug which targets these two classes, it is common to have hematological side effect. Otherwise, grade 3 for side effects were not much for this. So if we can bring odronextamab or any other bite for that case, which the trials will show, it is showing us some good result. And we can see the overall response was almost close to 100% in drug level 2 dose. And the we can see the CR was also tremendously better. And PFS in those cases where the DL was 2, drug level was 2, PFS, median PFS was not reached, and it is ranging in terms of 90 to 100%. So this drug is showing some good result. It was another study, another first-line trial of these drugs, mosunetuzumab monotherapy for elderly unfit. This is like daratumumab for elderly unfit, newly diagnosed multiple myeloma. So these patients are more than 80 years of age or 65 plus, but unfit for chemotherapy. So the performance status should be good, and they have done mosunetuzumab single agent subcutaneous therapy, easy to administer, but should be given with a prophylaxis for CRS in cycle 1 and 2. And it is also given as a step-up dose. First dose is 5 mg, and then second dose onwards, it's 45 mg. From second cycle, it is once a month. So 21-day cycle, weekly, every 3 weekly, 45 mg, and single drug, and you are giving it subcutaneous, very easy to administer for elderly, unfit, newly diagnosed high-grade B-cell lymphoma. And we have seen that the bulky disease were there and the patient's age mostly more than 80, and the response was beautiful. If you see here, overall response was 73%. Can you imagine a single subcutaneous drug giving us an overall response of 73%? So the sun is coming out. So this morning sun study have shown us a beautiful result. And as expected, cycle 1 had maximum number of CRS, and cycle 2 onwards, the CRS have gone down significantly. And infection is a worrisome point in these bites and CAR-T, both we know. So we need to give them prophylaxis and sometimes IVIG supplements also. But this drug has done good. And this was epcoritamab for DLBCL3. They have also used epcoritamab monotherapy, similar to this mosunetuzumab. Here they have chosen it as a single agent. Initially, the first stage 1 study was there where it has two arms, epcoritamab alone versus epcor-len. And now from the stage 2 in the expansion, they have removed the len arm, and the only this epcoritamab is tried. It was given weekly for first 3 cycles, then from fourth cycle onward, it is monthly. So total 1 year of therapy, epcoritamab 48 mg subcutaneous injection. Good enough. It has shown a significant CR and with a long median follow-up. And we can see that at 18 months of follow-up, almost those patients who have continued treatment, so 20% have continued treatment, with only 26% of patients have progressive disease. Most of the have done good. And at 1 year, the PFS was 54%, and at 1 year, the OS was 65%. So this is another promising drug where a single drug is being used, monthly dose, for elderly unfit DLBCL. You can't give chemotherapy, you can't give BR, you can't give RCAP. You are giving a single agent subcutaneous monthly once, and a response in the range of 65%. Very good. CRS was the commonest side effect as expected, then diarrhea. Compared to mosunetuzumab, epcoritamab produces less number of uh, hematological toxicities. So we see that the long-term durable response is there. Then we have seen with the star glow, when you combine glofit with gemox, that the response is sustained. Then Sunmo again have given us that mosun pola is good. Polagliflozin is another. Epcoritamab and mosunetuzumab, they have shown as they can be used as a single agent, first line for frail elderly more than 80 plus. And CRS is there in all these. Mosunetuzumab has CRS, epcoritamab has CRS. Apart from DLBCL and high-grade B-cell lymphoma, we have follicular lymphoma. Follicular lymphoma, these are a common abstract which we have highlighted. The fixed stroke duration mosunetuzumab was used in relapsed refractory follicular lymphoma after 2+ line of therapy. And they can see that after 2 line of relapsed refractory follicular lymphoma, if you're using this, the overall survival was in terms of 78 to 80%, median OS was not reached, and time to next treatment was also 64 months. Median time to next treatment means we are giving another 5 to 6 years median so that they don't require any treatment till such time. So this was a beautiful drug, and they have completed 5 year follow-up also. And we see that the median PFS was at 5 year, it was 56%. Median PFS was 61 month, and median OS was not reached. And if you see 5 year overall survival, it is almost 92%. So you can imagine a drug, single agent, after 2 line failure in relapse refractory follicular, it is giving you an overall survival of median OS of 91%. And if it is combined with janubrutinib for newly diagnosed high tumor burden follicular lymphoma, so what they did, they started janubrutinib at least 1 week before this bite. So first 1 week means 7 days is janatul, and then from day one they have added mosunetuzumab. So like step-up dose of mosunetuzumab, all know 5 mg, then the ultimate dose of 45. Then every cycle, single days mosunetuzumab, and they have done this. Those who have achieved, they got to continue with janubrutinib 320 mg daily. In first cycle, because of risk of CRS, steroid was used, and from next cycle onwards, steroid were withdrawn, and the patients also received prophylaxis for herpes and PCP pneumonia. GCSF is also allowed depending upon the degree of neutropenia. Every cycle was 21 days. We see the overall response with these two is 92%, and the complete response was 82%. It is beautiful. No chemotherapy, targeted and a bite. So giving you an overall response of 92% in RR follicular lymphoma with high tumor burden. And most adverse events were of low grade. Grade 3 adverse events were very few. Mostly they were deranged LFT. It was grade 3. And anemia was also there, which was in grade 3. Otherwise, there was no flagged safety signals. GLOVE is another trial which was for mantle cell lymphoma. So mantle falls in between. It can be indolent, it can be very aggressive. GLOVE was a trial where they have used glofitamab, they have used lenalidomide, they have used obinutuzumab also, although not mentioned in this heading. They have used venetoclax. So first cycle they have used obinutuzumab, and mostly they have chosen a high risk mantle cell lymphoma. So the high risk is when the KI is more than 50%. For mantle, any KI more than 30% is very high risk, and for MIPI-B, it comes in high risk. But they have done further higher, 50% KI. They have done something like TP53 positive by ISC or with FACE, and can be a case of complex karyotype. So chosen everything which is in red zone, and they see that most of the patients were in classical morphology with high KI more than 50%, and equal proportion of patients with TP53 mutated status, bulky disease. And they have included all this. They started venetoclax, step up dose, first 1 week 50 mg, another 1 week 100 mg, next 1 week 200 mg, and by the end of first cycle, from second cycle onwards, it was 400 mg flat dose for venetoclax as per the step up dose to avoid TLS. In first cycle, they have done obinutuzumab. From next cycle onwards, obinutuzumab was not used. Glofitamab, as we know, step up dose, lenalidomide was added from cycle 3 onwards. So glove trial have shown it was a phase 2 in high risk mantle cell lymphoma, newly diagnosed, and maintenance was a monthly cycle for first 5 cycle, and then from next onwards it was a every 2 monthly cycle, 56-day cycle. So 21-day cycle, then 28-day cycle for maintenance, and 56-day cycle for maintenance. In maintenance, obinutuzumab was not used, and what they have shown that almost 96% of patients has MRD negative. Can you imagine? Of all the patients with very high risk mantle cell, the MRD negativity is 96%. So thank you, team. And I would like to highlight that the field of lymphoma is very promising, and we can see that in lymphoma, most of the patients can survive if we are if we can employ BiTE, especially mosunetuzumab and epcoritamab, which are approved, also glofitamab. Keep in mind the risk of CRS, step-up dose, and tumor flare, but these are a good drug to produce some response. Thank you.
Thank you very much, Dr. Prakash, for simplifying the topics and very crisply pointing on the key update. So, if anybody wants to add any comment or ask any questions, I would welcome you for. So, if there are no questions, thank you, Dr. Prakash. So, now I welcome Dr. Amit Sharawat, sir. He is a professor in the Department of Medical Oncology at AIMS Rishikesh. He will be enlightening us about the advancing Hodgkin's lymphoma care, the essential role of its interest in every stage. I welcome you, sir, for the session.
Hi, good evening, Dr. Avriti. Thank you for inviting me to be part of this wonderful event. So, can you allow me to share my screen, please?
Yes, sir.
Hope my screen is visible and I'm audible.
Yes, sir.
See you.
Okay, so over the next half an hour or so, we are going to have an overview of advancing Hodgkin lymphoma care and the essential role of brentuximab vedotin, that is, etc., at every stage of Hodgkin lymphoma management. So, these are my slides are not moving. So, these are my disclaimers. So we are going to have a talk divided into three subsets. First, in front line setting of Hodgkin lymphoma. Second, relapsed refractory setting, and third, we are going to have some review of post autologous transplant consolidation in Hodgkin lymphoma with etc. So coming to the first part of it, that is frontline Hodgkin lymphoma management and etc. So to give a brief overview of the situation, we understand that Hodgkin lymphoma is having bimodal distribution of the disease. We see two peaks, one in earlier adolescent age group, 20 to 34 AYE age group, and then second peak in relatively elder population. Not just that, this age is also important in terms of prognostication, as we know that those patients who are diagnosed with Hodgkin lymphoma less than 60 years of age, they are having much better prognosis as compared to elderly population. And the treatment failure remains a risk despite high cure rate. So Hodgkin lymphoma is classically known to have curable in most of the patients, but still that despite high cure rate, cure is not possible for all patients. For example, around 5 to 10% of the patient will have some degree of primary refractory disease, and 10 to 30% of the patient will eventually experience relapse after initial response. And coming to the classical regime, that is ABVD, after ABVD in first line setting, up to 30% of the patients, they are going to die or going to have progressive disease within 5 to 7 years of the Hodgkin lymphoma diagnosis. So there is some unmet need for evolution for improvising the first line therapeutic option for Hodgkin lymphoma that we practice today. Other than that, there is one major concern about toxicity with standard multi-agent chemotherapy regime that we use as a part of standard of care for Hodgkin lymphoma management. So common toxicities like pulmonary toxicity, cardiac toxicity remains a major concern with ABVD. Other than that, long-term toxicities like fertility issues, secondary malignancy, endocrine dysfunction are also our concern. So these two set of unmet need are there, which need to be addressed by newer strategies. So what we are practicing in LMICs as of now, there are two standard therapeutic chemotherapeutic options of ABVD and BCOP. Other than that, there is this Indian approval of Adcetris plus AVD. So we are going to have some overview of the data for this current approval. So what defines success in Hodgkin lymphoma? Primarily, our aim is cure. With such a high cure rates, with all permutation common of patient, with advanced stages, age, and everything, still that remains highly curable malignancy. So our prime aim always remains overall survival. So in terms of achieving that aim, Adcetris plus AVD combination aligns better with our overall survival-driven decision making in this group of the patient. So what was the reference study for this population? So this was HL11 trial, which studied Acetris plus AVD versus ABVD as first-line therapeutic treatment options with previously untreated classical Hodgkin lymphoma patient of age more than 18, stage 3 or 4 with good ECOG performance score of 0 or 2. So around 1,300 such patients were randomized into 1:1 ratio of ABVD versus Acetris plus AVD. And PET-CT was done at the end of 2 cycles, and those patients who are having dual score 5 were excluded out of this trial and were offered alternative therapeutic options were not reported as median PFS event. And follow-up was planned at 3 months for initial 3 years, then every 6 months until the study closure. Primary endpoint for the study was uh, to calculate median progression-free survival, and that calculation was done by independent review. That was independent review facility was involved in documentation of median progression-free survival. What were the result? The primary endpoint, that is median PFS at 2 years, was 82.1% versus 77.2% in control arm. And as you can see, the p-value was 0.04 and hazard ratio 0.77. In addition to that, we have 2 more data sets that was reported at 6 year and 7 year. Now you can see there is clear-cut advantage of offering this strategy with 82.3% at 6 and 7 year PFS advantage. So there is statistically significant difference which is favored in the arm, that is intervention arm at Cetris and AVD as compared to ABVD at 2 year, and which was sustained well at 6 year and 7 years. Coming to the most important that we are saying, the most important endpoint, the golden endpoint, that is overall survival in Hodgkin lymphoma patients. So there was clear-cut survival advantage at 6 years and 7 years of 93.9% versus 89.4 at 6 years and 93.5 and 88.8 at 7 years. The trend, however, was seen as 2 years. So that benefit was sustained later on. Initial overall survival was almost same at 2 years in both the intervention as well as control arm. But the effect, the curve separated late, and there was clear-cut survival advantage at 6 years and 7 years. So to summarize, as we can see in stage 4 patients, overall survival was reported to be 94.2% with 51% reduction in risk of death. Less than 40-year age group of the patient, it was 98.2% with 61% reduction of risk of death. Not just like that, disease burden was also important implication. So those patients who are in baseline more than one extranodal disease site involvement were having 66% reduction in risk of death. So AB Adcetis plus AVD provides a longer overall survival benefit in this group of the patient. So this data was presented well before, and then this was one interesting JCO oncology practice publication regarding observation of oncologists, how they are deciding what are their aims while they are treating Hodgkin lymphoma patients. So as you can see, 91% of healthcare providers consider overall survival is the most important determining factor in terms of first-line therapeutic decision in classical Hodgkin lymphoma patients with higher disease burden, stage 3 and stage 4. And coming to the choices of first-line therapy of such group of the patient, Etcetera plus AVD remains one of the preferred first-line choices for heavy disease burden stage 3, stage 4 patients, as you can see in this publication, which was done in 2023. So coming to the summary of this thing, so summary of evidence, the patient's age more than 18 years, but less than 65 years of age, having stage 3 and stage 4 disease, having IPS score of 4 to 7, high-risk patients, and patient having more than one extranodal disease site are preferred candidate, are suitable candidate rather, are suitable candidate for brentuximab vedotin plus AVD. Coming to the second part of it, that is role of Adcetris in relapse refractory Hodgkin lymphoma patient. So this was one of the most important trial in this setting done till date, that is SGN 35003 trial. This was one international single-arm multicentric trial of phase 2 trial, which is designed to determine overall response rates. And that overall response rate was planned to be studied in heavily pretreated patients. Those patients have received multiple lines of therapy or received autologous transplant while the part of therapy. Such group of the patient were included. So what were the key inclusion criteria for the trial or for the study was relapse refractory Hodgkin lymphoma patient after high dose chemotherapy and autologous transplant. Age must be more than 12 years. There should be FDG avid disease by PET-CT and very good performance score. So this group of the patients who were having multiple lines of therapy exposure and were post autologous transplant, so in this group of the patient, any response is going to be meaningful. So that's why a primary endpoint design was overall response rates. Other than this key primary endpoint, other secondary endpoints were duration of response, proportion of patient receiving complete responses, progression-free survival, overall survival, and obviously safety data was also compiled. What were the results? So this was kind of unprecedented with this group of this inclusion criteria patients, that 75% of the patient were having some degree of response. And moreover, about 34% of the patient were able to achieve complete response with this strategy. So this 34% complete response after multiple lines of therapy, after high dose chemotherapy and autologous transplant, is kind of unprecedented till the date that data was presented. And as you can see in this waterfall curve, vast majority of the patient, 94% of the patient achieved some tumor reduction with this strategy. And the majority of the patient were not just any degree of tumor reduction, more than 50% of reduction in tumor burden was seen in vast majority of the patient, that is 94% of the patient. So this is kind of unprecedented data that was presented at the time of presentation of this trial. Now, overall response is one thing, then achieving that kind of response, timing is also very important. What time we are taking to achieve that kind of responses. So overall survival, overall response rate data when we are starting to see the responses was just 6 weeks. And those patients who were achieving complete response, that timing was just 3 months. So in within 3 months, heavily pre-treated patients, so those who are exposed to multiple lines of therapy, practically candidate for kind of metronomic or best supportive care, you were able to achieve complete response in 34% of the patient at 3 months of therapy. So at 5, this data was presented at 5 year of follow-up. The median overall survival in this group of the patient was 40.5 months. And median PFS in this group of the patient was around 9.3 months. This is also important to understand that we are also going to discuss that relapse refractory Hodgkin lymphoma scenario where EDCETRIS should be preferred are those patients who are autologous transplant eligible due to poor second-line treatment responses. This is one group of the patient, those who are going to be a better candidate or suitable candidate for EDCETRIS strategy. Other patients are going to be those who are relapsing after autologous transplant. Also, those group of the patient, those who are actually not a candidate for autologous transplant, but having relapsed disease after 2 lines of therapy, they are also going to be suitable candidate for this EDCETRIS strategy. Also, those patients who are having multiple comorbidities, practically we see in our setting, but are not a candidate for chemotherapy in low poor performance score. Excuse. So this group of the patient are going to be candidate for EDCETRIS strategy. So coming to the last part of the talk, that is post-autologous transplant consolidation strategies in Hodgkin lymphoma and rare cancer. So disease-related, patient-related risk factors are important determinants that which group of the patients are going to have relapse even after autologous transplant. So as we understand, there are certain factors which predetermine that which group of the patients are actually at a much higher risk of developing relapse after autologous transplant. So such risk factors include, to start with, patient is having stage 3 or stage 4 bulky disease. Those patients who are having more than one extranodal area involvement, pre-autologous transplant, patient with refractory Hodgkin lymphoma or early relapse progression after frontline therapy, those patients who are having relapse after multiple lines of treatment failures, those who are having chemo-resistant disease, post-salvage, there is no response to salvage therapy, and those patients who are having pre-transplant PET positivity or patient having B symptoms at the time of diagnosis or relapse. So you can see these risk factors are starting from the date of diagnosis to the date of autologous transplant and then post-autologous transplant. So all the permutation combination of the risk factors starting from the date of diagnosis to the autologous transplant, they are having important implications in deciding that which group of the patients are going to be, are at much higher risk of developing relapse. So they are required to be targeted with some additional strategies like consolidation. So this risk factor apart, there is one more important point is the timing of relapse. So patients having refractory disease and early relapse relapsers, they are having relatively much worse prognosis as compared to those patients who are having late relapse. So you can study this, you can see this important study that was published in British Journal of Hematology in 2012. So those patients who are having late relapses versus those patients who are having early relapses, you can see 5-year survival was 50% in early relapse and 73% in late relapse. So prognosis is much better than in those patients who are having late relapse, and that prognosis is sustained even at 10-year data set. You can see that those patients who are having late relapse were having 65% chance of 10-year survival versus those patients who are having early relapse were having just 46% chances of 10-year survival. So these two important facts that we must consider, that risk factors and timing of relapse. So these are going to be important decision-making points for those group of the patients who are potentially going to be candidate for our maintenance consolidation strategies. So overall survival is reduced after autologous transplant if patient have received multiple lines of therapy. So patients who are having more than 2 lines of therapy exposure before autologous transplant, they fare significantly worse than compared to those patients who have just received 2 lines of therapy. So you can see this data that was also a publication in 2012 said that number of lines of therapy are also having important implication in overall survival of patients post autologous transplant. So how we can target this strategy after these points? So first and foremost, we must try to achieve complete response. There must be PET negativity. So this is ideal world scenario. That is not possible for for all of the patients, not most, but for all of the patients. So this is not always possible. So we must also consider risk factor, and those risk factor, as we have discussed, that risk factor calculation start from the date of diagnosis and then various time phases of the Hodgkin lymphoma management. So after considering these lines of therapy, risk factors, and responses to the therapy, then we must define the consolidation strategy for post-autologous transplant patients. In this arena, this was one of the most important landmark study that was published in 2015, that is Athera study. So it was a phase 3 international randomized controlled trial. It was a placebo-controlled design. It studied Adcetris versus best supportive care and placebo. So primary endpoint was progression-free survival. That was assessed by independent review facility. Secondary endpoint was overall survival. So this is the trial schema. So how the patient were recruited in this trial. So patients were diagnosed to have Hodgkin lymphoma. Then those patients were stratified based on the type of response they were having and the resistant development, that refractory disease to the first line therapy, relapse within 12 months of the therapy, relapse after 12 months of the therapy. And then these group of the patients were offered salvage therapy. Based on response to salvage therapy, if patient is having any kind of response to salvage therapy, that is CR, PR, or stable disease, they were offered autologous transplant. Those patients who are having progressive disease were not part of the trial. So here, the post salvage therapy, those patients who are having some degree of response, they were randomized. So they were randomized into 2 arms: placebo versus best support plus best supportive care versus brentuximab vedotin. That was given 1.8 milligram per kg every 3 weekly up to 16 cycles. So what was the result? There was a significant meaningful PFS advantage at 5 years. At 5 years, you can see Adcetris group were having 59% progression-free survival as compared to placebo of just 41%. And this benefit of progression-free survival was more pronounced in those patients who are having more than 2 risk factors. So risk factors are important determinants of overall survival and progression-free survival in this group of the patient. Now, coming to the important concern or important clinical implication that we must all be aware about is about adverse event. So, how is the tolerance of brentuximab vedotin? So, you remember this is after multiple lines of therapy, relapse refractory patients. So, we can see that about 87% of the patient were having any degree of event. So, this is important to understand. There is going to be some toxicity, but this toxicity in vast majority of the patient is going to be grade 1 and grade 2. So what kind of toxicity we see? There are two important toxicity or two important side effects that we must always keep in mind. That are peripheral sensory neuropathy and neutropenia. You can see 50% of the patient, they were developing neuropathy, and 1/3 of the patient, they are going to develop neutropenia. So this is all grade neutropenia and all grade peripheral neuropathy. So these are the two most important adverse events in this group of the patient that we must all be aware about. So we have seen and discussed academically that peripheral neuropathy is an important adverse event of the drug. But having said that, this is important data that was published in 2018 that at 5 years of survival, 90% of the patient with peripheral neuropathy on etc. they showed some degree of resolution and improvement. Not and how was that degree of improvement? That is also important to understand that at 5 year, vast majority, around 73% or two-thirds of the patient, they uh, three-fourths of patients, they had complete response resolution of peripheral neuropathy. So in addition to that, at least there are three more data sets from real world scenario. One study is from France, Italy, and third study is from Turkey. So they studied this strategy of etc. consolidation after autologous transplant in these three countries. And that reference trial data was also kind of replicated in both in all the three trials. So this was not by chance. This is well supported by three different settings from three different countries from Europe, and you can see that they were able to replicate or rather improve, reported better progression-free survival at 2 year and 3 year in all the three countries with two studies reporting more than 100 patients and one study reporting 75 patients. Tolerance and toxicity was also relatively better in these real-world studies as compared to the reference trial. So that response progression-free survival was reported well in real world scenarios from at least three different settings with no major concern in terms of newer toxicity, or rather their safety data was even better from real world evidence. So what is the conclusion? That post autologous transplant Hodgkin lymphoma patients, patient with chemo resistance, patient having early refractory disease, early relapsers, they are a better suited candidate for post autologous transplant consolidation strategies. So what were the conclusion of the trial that of the study? That post autologous transplant consolidation with Adcetris in patient with Hodgkin lymphoma patient provide a greater PFS than placebo. PFS benefit observed with Adcetris was maintained until the study closure of 10 years. That means it was a well maintained response. PFS benefit was most pronounced in patients with more than two or three risk factors. And patient receiving brentuximab consolidation therapy require fewer subsequent anti-neoplastic therapy in future. So almost half, that 47% of the patient in placebo arm received Adcetris were subsequent as a subsequent therapy. Not that means that difference would have been much more if patient were just received placebo. So in there was crossover. So despite the crossover, that effect was statistically significant. So considering each patient's complete risk profile from the date of diagnosis throughout the course of Hodgkin lymphoma is probably the most important, crucial clinical decision making pointers or inclusion of consolidation strategies brentuximab in this group of the patient. With that, I'm going to stop here and thank you, Takeda, for providing me the slides, and thank you, organizer Dr. Avriti.
Thank you very much, sir, for this enlightened talk. Sir, what is your experience with toxicities with brentuximab requiring dose interruptions?
So actually, my experience is very limited. Only few patients with Uttam Saraj being treated, but overall, there is no major red flag that I can say with confidence. So whatever data that we are seeing from the trial, so it's not like that our patients are not tolerating well. Our patients are tolerating well, toxicity are well managed. And as you can see that in real world scenario, toxicity profile is better. And the concern of peripheral neuropathy is also there on a long-term follow-up that is resolved in vast majority of the patient.
We have such an esteemed faculty here, sir. Is there, sir, any comments from anyone else? So, thank you very much,
Thank you so
Amit, sir.
much.
Thank you, Dr. Avriti. Thank you for inviting me.
For the next talk, I would like to invite Dr. Farhan Naeem. Sir is Senior Consultant, Hematology, Bone Marrow Transplantation, Max Hospital, Delhi. Sir, I would love.
So good evening, am I audible? So am I audible?
Yes, sir, you are
Yes,
audible.
you are audible.
Okay, thank you, Dr. Avriti, and for giving this opportunity for today. So just I'll share my slides. So today's talk is on the polatuzumab vedotin in the management of diffuse large B-cell lymphoma. So it's a sponsored talk. So this is my disclaimer. The slides are provided from the Roche. So just starting that we know that what we are speaking that diffuse large B-cell lymphoma is the most commonest non-Hodgkin's lymphoma we see in our country. And I think this is the one a lymphoma which at times it's so easy to treat and some at times it's so difficult to treat. So we have a lot of heterogeneity, and from the last 2 decades there was no heterogeneity in the treatment. So there was only a uniform treatment available despite having a heterogeneity in the biology of the disease, which is still not well understood. And we all know that what is available is what we can do for the heterogeneity is we can only do the fish, look for the high double hit and triple hit lymphomas. Other than that, the molecular markers, the dark signature phenotypes is all been coming up. Still, it's not common and it's not under practice for everyone. So this that's the principles of treatment of DLBC. It's a long like it's something of old paper which is focusing what is the most important, and we all know. So the most important when we treat a DLBC is to achieve a complete remission. So most important is to treat with the best available drug and to achieve a cure. So those who relapses, they are bad actually. So those relapses early really do very poor, and those relapses late they are also doesn't do very good. So the best chance when we treat, especially in our country, in a resource constrained country. I will not say resource constrained. We have all the facilities, but still we don't have the finances available to afford a treatment which has subsequent lines which are quite costly. So the cure must be accomplished with the frontline therapy, and so this is something which is an important principle. And we should deliver the drugs at a curative doses. And this is another point, and I think which is very important when we treat a DLBCL. Someone who is not very unfit, very comorbid, we should try to give the doses which are curative, because as we know the first chance is the best chance for these patients, especially in our country. We should bring the disease into complete remission as rapidly, and we should not be very aggressive and providing too much toxic to the patient also. And we should be careful in this also, because losing a patient with febrile neutropenia lymphoma patient is very disheartening. So coming to the patient journey that we all know, that the first line treatment achieving cure, it's mostly possible in only 60% of the patients when we treat with the first line of therapy. And rest of the patients, they ultimately they progress or they are having refractory disease or they relapses later. So we have with the second line, depending on the time of relapses, we just go for the CAR T cell therapy or the autologous or allogeneic transplants. And those who are cured with these therapy, other patients we have don't have a very standard treatment left after that. So this is the R-CHOP. We know that it's standard of care since last 2 decades, and that's what I was discussing. That there is a lot of heterogeneity in the disease, which is still it is still investigational, but the treatment remained uniform for the last 2 decades, and it was R-CHOP. And there a lot of things being added. And since my training, I'm seeing there studies coming up that some be added. Sometimes we added ibrutinib, some added lenalidomide, some added. Uh, so these are a lot of that I will go to come to the next of the slides. So coming to the DLBCM, the in context of Indian context. So this is again very important. So multi-center real-world prospective observational study, which were done in our in our country, what it has shown that the best OR rates at 6 months was 90%, 2 year PFS was 69%. It's good, but the 2 year overall survival rate was 79%, which is nearly 10% less than in the West. So this is what it shows, that the subsequent line of therapy or treatment is very difficult in our country. So that's why it reflects into the overall survival rate in our country. So what is the unmet need? So those who have a low IPI, early stage disease, GCB phenotype, they have a high cure rates and they have a good cure rates even with the R-CHOP regimen. But those having a high IPI, these non-GCB phenotypes, Those who have
एक मिनट chance बता रहा हूँ.
double hit or triple hit. So these are the subgroups which are having a low curability, and they need something different from the archer. So this is the slide which shows the no benefit from several studies I was telling. So these are all being tried along with the R-CHOP, standard R-CHOP, but none has shown much benefit, except we have some subgroup analysis which like showed a benefit of lenalidomide maintenance in the elderly subgroup. But still, we don't have anything which has shown a significant improvement in the PFS or the OS. So again, I was discussing with my colleague who was in the ASH this time, and all talks were about the polar RCHP. I think the in the Western world, they I think stopped talking about the RCHOP and or being replaced with the polar RCHP. But I know that this could not be the case in our country. So we have to selectively select our patient judiciously who actually needs can be cured with the RCHOP and who actually needs something more than that. So this is the significant unmet need to improve the treatment outcomes with the DLBCL, and then came this study, which has, which after a long time has brought something new, something not, I will say not say new, but something which has an edge over the R-CHOP in some aspects, and this is the polar RCHP. So what is the polatuzumab vedotin? So it's an antibody drug conjugate targeting CD79B, and CD79B is a signaling component of the B cell antigen receptor, which is ubiquitously present in all the DLBCL patients. And polatuzumab vedotin consists of a potent microtubule inhibitor conjugated to a CD79B monoclonal antibody via protease cleavage peptide linker. And this is a landmark study, this Polarix trial, a global randomized double-blind placebo-controlled trial. So this is the study design. So the two regimens which were compared were the Pola RCHP and the R-CHOP. The polatuzumab has replaced the vincristine. And so this is the study design. So this is a phase 3 double-blind randomized trial. The patients who are included were a newly diagnosed DLBCL patient. Age was 18 to 80 years. So a good number of elderly patients were included. The IPS score 2 to 5 and good performance status. So at 5 years, the follow-up, the polar RCHP has sustained and significant PFS benefit, confirming the results from the primary analysis. And you can see the two graphs they are separating, and there is a PFS benefit. And this is what which is required in our country. We don't need to see overall survival in our country. That we have seen in the previous study from our country that anyway it's going to be less. If you do this study in India, if you start looking at phase 4 study, and you see that there will be they'll start coming the overall survival, as we know that subsequent lines of treatment are difficult in our country. So what is the first what we can give the best to the patients, and that's reflects from the progression free survival. So the patient treated with polar RCHP required 23% fewer subsequent therapies versus patient treated with the R-CHOP. So this is the overall survival. So again, if you can see, they have separated now their Asian cohort. And now you can see there is a OS benefit. The two graphs are separating, although they are separating, but still they are not statistically significant. But overall, but in Asian cohort, you can see the two graphs are separating, and this is the same imply for the country also. So now coming to the subgroup analysis. So although the study was not powered enough for the subgroup analysis, but still you can see that all the subgroup, you can see almost they got benefited in polar RCHP group. This is a 5-year OS outcomes, which show the consistent treatment effect of polar RCHP across subgroup in the global population. So coming DLBCL, so what I was discussing, it's a molecularly heterogeneous disease, and at few centers we are doing, but still it's not being done. It's not being, although it's not, we have the standardized methods to divide this into clusters, different clusters. This is genetic subtypes. So you can see these C1, C2, C3, C4, C5. So it is a DFCI and the NCI BN2. So in this EZB and MCD, so these are considered as a those who are a poor risk specialist. So EZB contains the so EZH2 and BCL2. These have a high risk. These they fear these are the unfavorable one. And the MCD group, which contains the mid 88, again it's the unfavorable group. And the C5 is unfavorable in this DFCI. So once we at currently we don't have this genetic subtype available at every place. So we have to judicially choose our patients. So otherwise, once it is available, so definitely we know which are the patients who are going to get benefit from the polar RCHP. So this, as per the cell of origin, if you see polaric study, so definitely the ABC subgroup that it was more benefit than the GCB subgroup. And coming to the again this is the subtypes across the gene of origin, so cell of origin, again genetic subtype. So you can see these unfavorable one, this MCD and EZB or the C5 cluster. So these are the one who are unfavorable, and these were the subgroups which got the more benefit in the polar CHP2. So the same thing, the cluster 5, you can see there is very, the graphs are separating. So once we have this molecular classification and genetic classification available, definitely we know which are the patients. But if you see the other subgroup also, it is not inferior. So if you see the polar RCHP and the RCHOP, so polar RCHP is at any point not in non-inferior. At some places we see, at some subtypes, subgroups, we see that it has an edge over the RCHOP. So at present, what I can see is the best available what we can give to a patient is the polar CHP. I know that finances are more this, it's much cheaper than the RCHOP is much cheaper than polar RCHP. But if it is not an issue, then I think this should be the uniform practice for everyone. But currently we know that the finances are issues, so most of the time we select our patient based on the age, those who have elderly subgroups, ABC subtype, advanced disease. So these are the subgroups we fear which they do well with the polar RCHP. So again, this patient with dark signature DLBCL. So these patients do well with the polar RCHP. So once we have this molecular subtype classification, we start doing for every patient. So we will be more clear which are the subgroup of patient which requires the polar RCHP. But as of now, what I can say, that if still it is non-inferior in any case. So if you have to choose between the two, and finances is not an issue at all, so polar RCHP definitely. Where the finances are incurred, then we have to choose our patient judiciously. So again, this is the Polarix patient with DLBCL and extranodal disease. So demonstrated superior PFS with polar RCHP versus RCHOP. And the elderly subgroup. This is very important, this elderly subgroup. So it's a well tolerated regimen, and those who are elderly, they have this. I think they have this. The only chance is this in this to give the first line is the only chance having to bring a cure. Those who relapses, very difficult to go to the subsequent lines. It's very difficult. So elderly patient, yes, definitely they are the one subgroup which especially needs this regimen. Coming to the risk benefit profile, so what I will say is the safety profile remained comparable between the two treatment arms with no increased risk with long term follow up. So it's a well tolerated drug. So it's still uh, many clinicians, they still have like more comfort with the RCHOP. They still want to go with the RCHOP just because of comfort. But if you see the safety profile, it's both comparable, and it's a well-tolerated regimen, polar safety, even in the elderly population. So coming to the selected adverse events of particular interest, if you say so, peripheral neuropathy. This, yes, it is something which was initially raised concern with the polatuzumab, but what we found in the study is that this is same, almost same in both the group. There's not much significant. So except this neutropenia and infections more in the polar safety, so we should be more cautious for this for when we are dealing with when we are treating with polar CHP for the neutropenia, aggressively treat for the infections, means we should treat early these patients. and otherwise it's a well tolerated regimen. So this is just to show the peripheral neuropathy, means patients who you can see in both the arms. So it is at the follow up 24 months, it was almost same. So coming to the so newer guidelines also now started recommending. So these are the EHA guidelines. They recommend both the polar RCHP now is there for these patients, but not in the someone who doesn't have any risk factor. So there's a two or more. They advise both in the regimen polar RCHP and RCHOP, and again that NCCN also includes the polar RCHP in the frontline regimens. So just concluding my talk, so Polaris is the first trial over 20 years to show a meaningful improvement in the benefit risk profile over RCHOP, and the long-term follow-up analysis confirms an ongoing and encouraging PFS benefit and a positive trend in OS, especially in Asian population. There is a difference in the OS benefit also there. The benefit of polar RCHP holds even more importance in the settings with limited availability and access to efficacious treatment in relapsed DLBCL, and it's a category 1 preferred regimen as per the NCCN and the other guidelines. So thank you. So any questions, please?
Thank you very much, Dr. Farhan. I just wanted to ask one thing that do you have any experience with the Pola RCP, like omitting doxo in this elderly group, and what have been the outcomes in such patient profile?
So, Dr.
In any case,
So yes,
have you used Pola RCP?
so those who are elderly who cannot tolerate well, so we have two regimens. Either we can go for the Pola RCP, or even I have used the Pola BR also sometimes. Those who are not fit to receive anthracycline, so still we can give some meaningful, like some a good quality of life to these patients, although it's these regimens are not curative, but yes, we can use. So these two, so I use these, both these I'm using in the very elderly subgroups. This was, I recently treated a patient who was 95 years, but at least I can achieve a complete remission, although this patient later relapse. So we just get a PFS of 1.5 years, but even that is good in a 90 years lady.
Definitely. That seems nice. So thank you very much, Dr. Farhan. Now I would like to welcome Dr. Mukul Agarwal, sir, who is the professor in the Department of Clinical Hematology at All India Institute of Medical Sciences, Delhi. He would be enlightening us about Beyond ABR study and the other updates in hemophilia from ASH 2025. Welcome you, sir. Am I audible?
Yes,
Uh,
ma'am, you are audible.
Okay. Dr. Mukul Agarwal, sir is here. You can see his name on screen, but Has Dr. Mukul Agarwal sir has joined? Anybody from the technical team,
Yes,
please
ma'am.
just have.
Yes, ma'am.
Yeah,
He is
doc
fine.
Okay.
Hi, sorry, just had a bad network.
Mm. Good evening, sir. Welcome, sir.
I'm really sorry. Just
No, no,
internet
it's
got
not. It's not
snapped
happening.
at a very bad time. I hope my screen is visible now.
Yes, sir.
So I'm starting. So thank you, Dr. Avriti and team. So my topic for today is beyond ABI study. This is based on emicizumab, and I'll be discussing about some of the other oral abstract which were presented at ASH 2025. So mm, so this is it. So some other abstracts, around five of them, I will be presenting from the ASH, and just a brief about these. What we know about hemophilia is that the joint damage and the irreversible arthropathy which occurs, this is incremental, and it occurs over time. This occurs because of breakthrough bleeding, which is obvious joint bleed or the clinical joint bleed. It can occur because of subclinical joint bleed, which is even common in moderate hemophilias, and underlying inflammation. And this is something which increases with each bleed. It increases with age. It's increasing in a linear fashion in which every bleed contributes to further damage. That is why it is said that it is almost agreed upon that we need to start prophylactic treatment as early as possible to prevent any kind of clinical as well as subclinical joint bleeds. And that is why the importance of keeping the nadir factor levels higher, even more than 5% is advisable nowadays. Simultaneously, the patient need to undergo extensive physiotherapy to preserve their muscle strength and functional ability. So when these bleeds occur, leading to osteopenia and this becomes a kind of a vicious cycle which leads to the treatment goal shifted. So with time, we know that initially we were going on FFPs and now we have gene therapy in place. So the shift with this shift, the initial goals of treatment which were there, they have now shifted drastically and now to a more holistic kind of approach. So when initially the goals were of survival, now we aim to go for normal hemostasis, and in between a functional cure kind of a concept has arisen, where the patient can lead a nearly normal life and they are able to sustain normal mobility. They're able to sustain minor trauma without much increase in the bleeds, and possibly able to undergo minor surgeries without numerous intervention or limited interventions only. This normal hemostasis is still a distant goal without the availability of gene therapy. The problem lies with the health equity, where many of the patients are stuck somewhere around here only, and a very few, especially in the West, they are able to go towards beyond ABR. So, just a part of the study from the Haven trials, we know that the hemophilia A quality of life physical health score, they were improving with times, and as early as 3 months, there was a decrease in the physical health scores, and week 49. A similar kind of things are seen with the mean HJHS score in both the type of patient, whether they had a target joints at baseline or not. And this improvement was sustained, and with the improvement in the HJHS score, and again in both the younger or elder patient more than 40 or less than 40 years of age, where improvement in the hemophilia joint health scores was seen. So this abstract was presented at this year ASH and was published subsequently in the blood uh, as a in the abstract book. So this is the joint health and physical activity in patients with hemophilia A without. So this are the phase 4 multi-patients, more less than 70 years of age, more than 12 years of age, without inhibitors, and these patients have switched from the factor 8 prophylaxis to emicizumab, and these were observed for around 3 years. The assessment was based on not on the ABS but on the hemophilia joint health score, their global Gale scores, and IPAC SF score and physical activity tracker. So IPAC SF is International Physical Activity Questionnaire, and physical activity tracks were used for these patients. So just to brief, in the first 6 months, that is from week 12 till week 24, almost 80% of the patients had zero bleeds. This persisted in the subsequent 24 weeks as well. This was reflected in their mean HJSS summer joint scores, which improved by -2 at 6 months and by -2.8 by week 12th month. Similarly, if we see that around a quarter of the patients, they reported improvement in more than 4 points. So 25% of these patients had significantly more improvement in the HHS joint scores by month 12. That is, by 1 year, a lot of them were having significant improvement. So, what is a problem joint? By definition, they were defined it as joints with chronic pain or limited range of movement due to compromised health joint integrity with or without any persistent bleeding. So, just joint limitation or pain was persisting, even though the bleeding was occurring or not. So, if we see from this figure, both patient and investigator related outcomes were there. Even though almost 50 to 60% of the patient had no changes in their problem joints, but you can see from the green portions that some of the patient, maybe around 20% of the patient or 25% of the patient, in both these parts, they had a decrease in these problem joint by one or two. So the number of problem joint, they were decreasing at least around in a quarter of these patients. Similarly, if we look into the physical activity, more number of patients were able to do moderate and high end physical activity uh, by third month and by 12th month. So whatever improvement was seen, most of these improvement was seen by around 3 months, and this improvement was sustained by year end as well. So more number of patients were able to do moderate or high end activity. So some other abstracts from the ASH. This is about the females with hemophilia in tune with the World Federation of Hemophilia theme from this year. So around 530 eligible females were seen, and they were screened for factor 8 variants. And the most common variants were missense mutations, and some of them had multiple mutations as well. It was seen that around 329 patients had factor 8 variant, and in around 200 patients no mutation was variant was identified. Of these, significant family history was seen when the variant was identified, around in 96% of the patient, and if without variant, around 25% of the patients. Factor 8 activity mean was around 50% here and 66% in this group, and bleeding was again slightly more when no variant was identified. So it was seen that around 44% patient, that is 59 or 130 patient, had at least a moderate hemophilia kind of factor level less than 40%. And if we see the into the bleeding data, almost half of the females they reported excessive bleeding, and half of the female with the hemophilia positive and bleeding syndrome had factor 8 level more than 40%. So even though factor 8 levels were more than 40%, almost half of them were having significant bleeding. Coming to the second trial, the mimate prophylaxis. This is a imicizumab kind of a drug, and again given on a weekly basis. So this is from the Frontier 2 studies. It had a 281 randomized patient on demand and clotting factor prophylaxis. Two kind of lead-in arms were there. So in the on-demand prophylaxis, the median ABR decreased to around 0.43, and in the in if Mimate was given on a monthly basis, and if it was given on a weekly basis, it was around 0.43, and on monthly basis, it was around 0.25 only. A similar kind of results were seen if the patient was shifted from clotting factor prophylaxis. A lot of patients, almost 85 to 90% patients had zero bleeds in the on-demand from the on-demand group, and around two-third had from the clotting factor prophylaxis group. Adverse events were common, but they were mild in nature, mostly in injection site reactions. Around 7% of the patient had antibodies against Mimate, but they were non-neutralizing kind of antibodies and low titer, and no thromboembolic phenomena were seen. And there were improvement across all the patient-reported outcomes over the 52 weeks interval. Next abstract is about the safety and efficacy of emicizumab during immune tolerance implementation. This is from the Japanese group.
So you're not audible.
Hello? Yeah, so this is about the gene therapy trial. So this was published in December in NEJM. So factor 9 gene therapy, 54 patients, 50 patients had completed 5 years follow-up. Median ABR had decreased to 1.5
Sorry, your
from
screen is not visible.
not visible. Okay. Is it visible now?
Yes, sir,
Yes.
it is visible now.
So this is about this trial about the factor 9 gene therapy in 54 patients, of whom 50 had completed 5 years follow-up, and this was subsequently published in the December, just earlier this month only. The median ABR had decreased to 1.52. The median ABR is 5 years is around zero point 0.4 only. Mean endogenous factor 9 level are stable, and they are stable at more than 35%. So kind of a very successful kind of a gene therapy approach with factor 9. Exogenous factor 9 consumption had decreased significantly. Uh, Many of the patients had a treatment-related adverse event. This was mostly liver toxicity, and a good amount of these patients, around 20 odd percent, 15 to 20% of these patients required corticosteroid-based therapies for around 3 months median. There were three incidences of carcinomas, but they were confirmed to be unrelated to AAV genotoxicity. These can be explored in detail from the articles, and all these events had been reported previously in the literature. Last is about coming to CAR T therapy in the hemophilia A model. This is a mouse-based model in which factor 8 CAR construct was made with linking of C1 or A2 domain with these, and the lentiviral approach was used for transduction and enabling the CARs to recognize the B cells, so that they are able to selectively eliminate the B cells. Uh, In vitro cytotoxicity assays were done, and in vivo mouse model were studies in which a factor 8 knockout mice was studied with, and it was immunized with factor 8 protein, leading to inhibitor formation, and then CAR T was administered. So overall, the in vitro cytotoxicity was demonstrated with C1 and A2 CAR T cell able to kill the target cells equally. In the mouse model, C1 and both A2 CAR T cells, they were able to reduce the factor 8 inhibitors, and in the humanized model, therapy was able to show that it was able to eliminate the inhibitor generating cells. So overall, the titers of factor 8 were improving. This is a mouse-based model, but a very interesting approach which can be further incorporated into clinical trials. There were other few abstracts like the long-acting factor 8 efanesocog alpha, in which 4-year data was shown. The emicizumab prophylaxis in previously untreated and minimally treated patients. Marstacimab trial with the on the result from the phase 3 basis trial. NH3 prophylaxis, which is kind of very similar to emicizumab platform, and lastly on the prediction of the HCT scans. So overall, an eventful year from the ASH with respect to lymphoma.
So you're not audible.
You are not a
Like the presentation is,
Yeah.
I'm sorry, just
Uh,
had very bad network in between.
no, no, sir. Thank you very much, sir, for this talk. So I just wanted to ask you some questions, sir. Like, what is your experience in screening, like, of carriers? How frequently you are screening carriers for hemophilia in your
So
practice?
we had a departmental thesis in which we screened more than 50 carrier females. So this was done as a part of thesis only. Otherwise, it is done on ad hoc basis and as and when required basis. Many of the patients they come for prenatal screening, so that is when we screen. Otherwise, as a part of thesis, we screened over 50 females in this regard.
Okay, so thank you, sir. And sir, where do you place imicizumab and rebalancing therapies in your practice? Because now we have both the agents available. Think so, sir. Thank you very much, sir. So for the next session,
Experience per se is
yeah, okay.
limited as of now. And hopefully, with the appropriate pricing and availability to more patients, we should all be able to gain more experience with it.
Thank you very much, sir, for this enlightened talk. So now I welcome Dr. V. A. Arun. He's an associate professor in Department of Medicine and attached to Division of Clinical Hematology at INSH Ashwini, Mumbai. I welcome him for the talk on practical consideration for management of IC ineligible patients with Ven-Aza.
Yeah, thank you, organizers. Hope I'm audible.
Yes, sir.
Yeah,
You're audible.
I'll just clear my screen. Is my screen visible in the slideshow mode now?
Yeah, it is visible.
Yeah, thank you. So, thanks once again, organizers, for giving me an opportunity to connect to this crowd with this topic of AZAVEN in the management of acute myeloid leukemia patients who are intensive chemotherapy ineligible. We must understand the context of the talk because this is most of a hematology update, and I would be talking mostly, I would say, what we know already. But what is important, for as an update is this drug is now available in our market since April 25 in the commercial form. So previously it was, all, compassionate access and some nefarious means of accessing this drug. Now that, venetoclax is available to each one of us, I think we will have more data emerging from our subsets of patients who get benefit from this wonderful drug. So with that background, let me just go ahead with my slide. Yeah. So the important thing is AML really doesn't give you much time because it's a fairly aggressive malignancy to have because there is unchecked proliferation of the myeloblasts, and they can have access to wherever blood flows. So from the marrow all to all organs, visceral organs. So you actually, I would say time is of essence here. Important to know like the classification systems have evolved. This is a disclaimer from me that all these slide sets are, what AbbVie has given us. So that's why my talk is restricted to these slide sets. But we now know there is a better classification systems, both from the WHO and ICC, and we have moved from morphology to a highly cytogenetic and molecularly based classification. So this is from the SEER database. In fact, in our country, like most of the diseases, we generally don't know what actually numbers we treat and what is the real world incidence of, I would say, newly diagnosed AML in our country. Although there is some effort from the Hematology Consortium, which of course I'm part of, and there is some data which we keep dishing out, but we don't have any representative data. But what I would say, like most of it, we would have a baggage of around 20,000 odd cases in at least in our country as well. The median age of diagnosis is definitely, I would say, around 65 to 68. It's important to know because, we keep, this is an important age subset because the treatment fitness is, to some extent, I would say it's not an entirely magic number of age, which is, make patients eligible or not eligible for a therapy. But we must understand that our 65-year-old is akin to a 75-year-old Westerner because some of the observership we did out abroad gave us that insight that these trials which happen not in our population subsets, when we apply directly to our population, they don't tolerate this kind of toxic, or I would say, intense therapy. Although Azaven is supposedly, less intense, even Azaven as prescribed in the YLA trial, no, that is not applicable to our population, basically because of this fitness issue. And you would see a large amount of patients, even though you'll see there is a data from AIMS as well that most of the patients don't opt for therapy because of economic constraints and financial constraints. And for those who opt out for therapy, how many have burden of infections which preclude them to receive any kind of intensive therapy is something we must know. So these are fairly straightforward. What actually are the risk factors for AML? This is a very, I would say, a rush crowd here. I don't have to explain any of this to the group. So the symptoms usually the patient comes across are, very vague symptoms, and that is why there is a delayed presentation. In at least in our OPD, we'd see even with, best of access to therapy, sometimes the access to the hematology center is delayed. And then they go into these cytopenias, and depending upon what cell line is low, you can have complications, accordingly. So important in diagnosis of AML, is, you have to go through this morphology, and then it's not just morphology these days. You go into immunophenotyping and cytogenetics and molecular genetics is a very basic in AML diagnosis. And it's always easy to compartmentalize these patients into two subsets, the young fit and the older unfit. Although you have criteria which are, easy to, reproduce in a paper, but in a clinic, you will find them very difficult, mostly it is an eyeballing, I would say, because these are Ferrara criteria for easy, it's listed out beautifully in terms of age and organ function, whether it is the echo findings or the DLCO. All these are parameters which are laid on, but most often or not, just because of the access to therapy and late presentation. Some of our patients are too unfit, not only because of their age, but also because of the comorbidities which they have. We have very standardized way of assessing. These response criteria have also been refined very recently, like the morphologically leukemia-free state no longer exists in the present classification. We initially spoke about CRs, which is complete remission. Now, because we have less intensive therapies, two more categories came in, that is CRI and that is remission with incomplete hematological recovery. That's what most of these, less intensive therapies do. And this is what we must be mindful about. Not every CR plus CRI is same as CR when we, start comparing these two standard regimens. So this has been a bread and butter intensive induction with an anthracycline and a purine analog, and then we had access to these hypomethylating agents in the low intensity induction arm, but that was way back, and then we some of these patients who went on to get a transplant as a consolidation did well. So basically it was, if you censor out patients who got transplant, they are in the non-favorable risk. Not many would have survived beyond 5 years. A 5-year survival rate as on date is even 10 to 20% for those more than 60, and it will be around 30% for those above below 60. So AML is not an easy disease to treat. So what did some of the molecular genetic parameters gave us insights into is some of these mutations, the FLT3 mutations are something which are targeted, and we have access to midostaurin and, sorafenib and even gilteritinib for some of our patients. So we are using some of these targeted therapy in the intense arm. But for those who are not suitable for intensive therapy, we have moved on to that HMA plus therapy. And that's where, this classification clearly brings out, when you have an eligible patient who is eligible for intensive therapy, the West has gone into a triplet mode. They are now combining, FLAG-IDA and venetoclax, CLIA-venetoclax. With, their data is good with single digit mortality rates and, no induction mortality, but we can't recreate all this. And so we have to be very clear how much we do for our patients, not it should not come at the cost of safety. If you see the elderly subset, those above 60 years, the trial, the data is further dismal, you see, despite what you do. So that's when actually this venetoclax molecule comes in, because it's a drug which specifically targets the pro-apoptotic protein BCL2 and thereby facilitates apoptosis of these blastoid cells. And that's what actually, venetoclax was a very good value addition. But we must be mindful to know that even when you use single agent venetoclax, if you see the way it was utilized to 1200 milligrams of venetoclax with single agent, the CR/CRI rates were 16-20%. But when you add it with an HMA backbone like azacitidine or decitabine, the responses pick up. That's what the phase 3 landmark study, which led to the drug approval in newly diagnosed patients, told us. A beautiful study randomized in a 2:1 fashion to azacitidine and aza plus venetoclax. And this is, we must understand this. You see, the primary endpoint here is a composite CR rate and overall survival. There was a beautiful ramp up which was done in the trial. Some of us don't do that ramp up sometimes because of access to all the strength we don't have. And we must be understanding this is, this is a very niche group which was newly diagnosed and were not eligible for intensive therapy, either by age or by fitness. And it was treatment till progression or unacceptable toxicities. So when we apply this trial data to our real world patient, we must be very mindful of, these inclusion criteria. And you see this, there is some follow-up which came up maybe at the end of 2 years, and actually the trial one, it's, I would say the hypothesis in the sense there was some definite CR rate improvement, and you can see the overall survival curves with the Venaza 14.7 versus 9.6. Even with 4-year follow-up, we see these curves do separate, but we do see some kind of, don't see so much of flattening. The curve finally falls off. That tells us that when you stop Venaza, subsequently, you must be very watchful for those patients, because the standard of care has always been indefinitely continuing Venaza. So adverse events definitely are a part of this therapy, and the most important, I would say, and treatment defining sometimes are the neutropenia, febrile neutropenias, which are to the tune of 40 to 50%. These are something because the average duration of neutropenia with Venaza is at least 25 to 50 days. We know when we do transplants, every day of neutropenia counts, and how much that adds to the burden of, antibiotics, microbial resistance, drug costs, and all. So we must be mindful when we use venetoclax, and we must be very clear with some of the objectives which we have in mind. So I'll just discuss a case and wind up in last 2 minutes. So we have a 60-year-old male with this background comorbidities, and he has a RUNX1 mutation, and this puts him into, a kind of poor risk AML. And today I think most of us would latch on to venetoclax or azacitidine kind of a regimen kind of a patient for this. So important to know is, do you actually follow a 3 to 4 day ramp up for starting venetoclax? So what I do is mostly I do when with posaconazole, and sometimes the patient are too fit. We do want to do cytoreduction. So do cytoreduction with hydroxyurea or low dose cytarabine. Bring down the counts to less than 10K so that the TLS risk is low. Do allopurinol and rasburicase if required. Then start ASA. Add when. I use when and POSA simultaneously. I don't do POSA later on like what most of the trial data recommends. And when I do posaconazole, you can go down to 50 mg of venetoclax. That saves the cost as well. But now the pill is available with us. It's not that costly. Head to head, if you compare also the 7+3 versus when it's not, it's the cost is almost the same. And when you apply when to your patients, please don't apply the ELN 2022 classification for risk stratification. You have a definite set of a genetic signature-based classification based on FLT3 mutation, RAS mutation, and TP53 mutation. Don't apply the ELN 22. There is an ELN 24 revised classification, which has also undergone some kind of external validation. We did find out there were some subgroups of AML who would benefit better with azaven. That were the TP53 wild group, those who did not have the FLT3 ITD and the K or NRAS wild type. We do also know the NPMs and the IDH2 mutant patients do better. When it comes to antifungal, I did tell you about doing POSA or VORI with azacitidine and venetoclax. But although the recommended dose with VORI is 100 mg venetoclax, and it is 50 with posaconazole, I do 50 because we know that most of the patients can't tolerate more than 14, 21 days of therapy. It does bring down the cost as well, like what we said when we did not have access to this therapy. So the West has published data, their fungal infection risk is 3 to 6%. They said we can do away without, the antifungal prophylaxis sometimes, but at least in our settings, we are very mindful about giving, because some of our patients do come with, aspergillus pneumonia and so on and so forth. So there is some, discordance in what EHA and ECIL recommends as far as anti-infective prophylaxis goes when you do azaven. The dose modifications I said, we must know whenever you use a strong inhibitor of CYP3, like the POSA or voriconazole, we should not be using the 400 or 200 when. That is what is very clear. So when do you assess the marrow? Like, the basic premise of doing an early marrow in venetoclax, was to reduce the toxicity, the myelotoxicity of, and profound neutropenia. So do as less as possible. The minimum is, I would say, so although there is data from Tata and all, which they do even 14 days or even 10 days. The French data of AZA plus when for 7 days is also out. But the standard teaching has always been, and what I do end up doing is, 21 days to 28 days is when I do the first marrow to see whether there is blast clearance and marrow is hypocellular. If there is blast clearance, then I do GCSF for my patients to facilitate neutropenia so that the second cycle, usually you can start by day 42 to 45. That's what we end up doing. And this is what, most of our patients end up getting, what is important to know is when you do azaven, the CR rates keeps improving by third or fourth cycle, you see you get around 90%. Most of the patients who have to respond would respond on third to fourth cycle, okay? Because somebody who responds early or late really doesn't matter at the end of the day, because you would have some kind of consolidation which will be required. That is what we must know. Before achieving remission, please don't interrupt venetoclax. That's the importance of an early marrow. But after achieving remission, definitely if you have neutropenia which is ongoing, utilize GCSF in the first cycle. And if there are profound neutropenia, subsequent neutropenias, reduce the duration of venetoclax. That is what I would do rather than reducing the dose from 21 to 14 to 7 to 5 to 3. Anything. I think even 3 days of venetoclax is good. That's what data shows. So I do use GCSF if the marrow doesn't show any blast. A large proportion. So there was some confusion whether when you use GCSF, does it differ? The CR/CRI rates or overall survival rates differ? But there is data that it really doesn't differ. So how do you assess for relapse? Some of the molecular mutation like NPM are molecular MRD markers now. We can utilize them. For those where there are no molecular markers, we do marrows, at least for those who are on azavan at the end of first cycle, then we do, marrows at 6 months and 1 year. Then we leave it to the patient, nobody is ready for a marrow aspirate that frequently. So we are just not doing any marrow. We go by the clinical parameters. So important to know how long would you stretch azavan for your patient before switching to alternative therapy. So this is something which must be clear. So failure to achieve a CR/CRI, or in previous trials, they talk about MLFS. At the end of sixth cycle, that is when you actually take a call and say the Ven-Aza has failed. And these are the patients who really won't do well with any kind of regimens. And these were, the selected group who were like, they were TP53, they were secondary MDSs. They really did not do well with the ASA when kind of regimen. So that's all from my side. And I stuck to what the ambit of my talk was. It was to talk about how to utilize ASA when with practical tips rather than just an update on this. I know there was a lot of ASH update which came, including the paradigm, the Viceroy. We can talk about trial, the triplets, so much with venetoclax backbone. But I think I just did justice to what the organizers and the industry wanted me to speak about. Thank you. Thanks for your patient hearing.
Thank you so much, sir, for this insightful talk. So I just wanted to ask that what is your experience with triple drugs?
So I don't
Especially
I haven't done a single triple now, and I don't plan to do it also on a routine basis, because we being from the army, we have access to all these drugs. Access is not an issue. When I understand and see my patients, the way it has to be done, most of our patients are not lost to follow. So we are very clear with what we do. So we do around 30 to 50, I would say, AML inductions. So in those we are very clear. So I haven't done any. I know there is data with the triplets, beautiful data from MD Anderson and single center data, but I'm not going to do, a triplet induction for my patient upfront because I think it's too toxic. Rather, we are talking about, flag when for our newly diagnosed AML patient. That is something which is in my mind and is being part of a randomized controlled trial. We have put it up as a proposal to the Hematology Cancer Consortium. So you can consider that as a triplet. But the anthracycline is profoundly toxic for our patients. So I just don't want to add anything more to that. FLT3 inhibitors we have done, but sometimes they are not very tolerant, and the data comes later because the FLT3 data comes sometimes 5 days later, or maybe even second week sometimes. So I know there is data with IDH1 inhibitors as well, but and AZA and ivosidenib doing well in such subsets. But these are all to be taken with a pinch of salt. We should not apply to our patients from tomorrow. I think we have to do it in, as a part of a trial and know how much our patients can tolerate. We should be very selective for our patients. Yeah.
in some scenarios, do you see the TBCs and decide on the dose of venetoclax? Because in my experience, I've seen that those people who are responding early, their platelet counts start improving early, and if their platelet count starts improving early, it gives a clue that the disease is trying to it is an improving trend. So, in your clinical practice, do you use because most of the patients who are in regimes, they're not very keen on early bone marrows. So in those scenarios, do you change on the duration of the venetoclax?
No, so most of the ASA when we have done, we stuck to that, day 21 to day 28. But most what I'm seeing is when you use venetoclax early, by 14 days, usually they're profoundly neutropenic. I don't think that might be advisable, but like what I've also observed what you have said. So like the platelet coming up, that may be an indicator. But whenever we have more objective parameters, I think marrow is a very good uh, window to the patient's fitness. So I would rather go by the marrow metrics than just count recovery in the periphery. It may mean something else, and there are so many heterogeneous subsets, no. So it's very difficult to make, blanket statements like we can do this or not. But I stick to the trial and just stick to what the trial did tell us. And we have learned that marrow at the end of first cycle early on helps. That is what we have been insisting. Subsequent marrows are all, like what you said, we generally don't insist. The patient usually is not ready when they are on palliative kind of a treatment or less intensive therapy. If they're going for consolidation for a transplant, that's again when we do a marrow again. Otherwise, we are not very strict with marrow subsequently.
Thank you very much, sir. So for the last session, Dr. Fahima was supposed to join, but because of some urgency, she was not able to join. So she'll be taking part in the day 2 session tomorrow. So thank you very much, everybody, our esteemed faculty, for joining and sparing their valuable time. I'm sure all of us have gained a lot from your vast experience. Tomorrow, we'll see you all for the day 2 sessions. Thank you, everybody. Good night.
Thank you.
Tech support. Tech support. You can hear them.
Yes, sir. Can we close the room?
Yes.
Okay, thank you.